She's back on Healthcare Unfiltered, which means it's my lucky day and listeners' lucky day. It also means so far I have not messed up as a host, so that's really good. But since the last time Dr. Dusetzina was on the show, she has become a professor of health policy. So congratulations.
Thank
We
you.
are taping this in February 2023. For the few listeners out there who don't know you, which are very few, by the way, just for the record, but maybe a little bit about you and what you do, because you really have an interesting background, I would say, in terms of how you juggled between industry and then you went back to academia.
Yeah, that's right. So, hi to the listeners, or hi again if you've tuned in before. I am a health policy professor. I came out of industry. I worked in contract research organization for a few years before going to grad school, and had the pleasure of working on many clinical trials and getting to see that up close and personal, and some of these high risk, high reward endeavors that are clinical trials in the pharmaceutical industry. And that made me really passionate about thinking about how people use medicine and access to medicine, and took me down a path of getting a PhD in pharmaceutical science. And then subsequently, I've been working in the areas of healthcare policy and specifically prescription drug policy, mostly kind of trying to balance the research around access to drugs, the fair prices for drugs, and how much patients pay, and how do we make sure that patients and society can afford to pay for prescriptions. So I'd say that maybe is, in a nutshell, kind of the way I approach my work, and what informs my work.
But truly, you understand the drug pricing, Medicare, Medicaid, and all of these things like no one else. I mean, one of the episodes that me and you taped was about the Inflation Reduction Act, which was very educational. I mean, it's really a very good one. So we appreciate that. And as I've told you before, you have job security. The healthcare system will continue to be screwed up. So don't worry. We will always need you. We're not going to fix it. You know, it's like taking the car to the mechanic. They fix something maybe, but they keep so you can come back. But
That's right. That's right. I think the good and the bad is that there's always going to be something to do. I think probably I shared with you on our last conversation around the Inflation Reduction Act that they fixed, or they are in the process of fixing, so many things that I've been focused on in my career, as like demonstrating how it's broken and how we should fix it to make it better for people. And so I did have a brief moment of like, oh, am I done? Like, should I just stop? I actually feel like I helped to solve this big problem that I was really focused on. And then, within about 45 minutes, I was like, oh no, there are lots of problems.
well, I've told you this before that I predict you're going to be in office at some point. I really do, genuinely do, and I would love to see you doing something there. Whether this is, FDA, whether this is, Medicare, I don't know, but I think you obviously are very qualified. I just wish that politics were easier to navigate, because there are a lot of smart people who want to do well, and then they go to Washington and they realize it's not as easy as you think it is. So as usual, I bring you in for topics that are non-controversial and very easy, and today we're going to talk about PBMs.
Yeah, I think you also bring me in when you said, oh, okay, we'll have a conversation about PBMs. I was like, wow, this is a really deeply nerdy audience. I embrace it. I love it. I am glad that people are interested in PBMs, because I think that it's important to have these conversations to think about what role they play in the system, and the good and the bad of them. Because I think that it's really easy to paint PBMs as a bad guy in the current system. And so I always like to kind of think through, all right, well, why are they there? How did they get there? What are they doing? Like, what are they doing that actually has allowed them to persist and to grow so much. And so I'm glad we have the chance to have this conversation.
I also think a lot of people don't know, really. I mean, I think we just have to like you said, I mean, I don't know how long back you want to go back in history to understand how they even evolved. There was a time in America where there were no PBMs, obviously. There was a time that existed, I don't know, the 60s, 70s, or 80s, I don't know. But let's get back, and I see myself here frozen. I'll move okay, I'm back. Let's talk about, first of all, what are PBMs and when did they even get incepted? I don't know, whatever you can give us history-wise, why, who are they, who started them? Did somebody just think about this? Like, what happened?
Okay, well, so this is probably going to be even beyond my knowledge because I actually don't know as much about the foundational history. So I think this would be something interesting to go back and trace back, but I'll tell you kind of generally what PBMs are and what role they play and why I think that they kind of developed and grew in the way that they did. So PBM is a pharmacy benefits manager. So just so everybody knows when we say PBM, what we're talking about. If you think about it, and when I teach, I explain like the role of this entity is to basically set up and manage pharmacy benefits for different groups, largely for employers and companies. So if you were thinking about if your employer wanted to offer you prescription drug benefits, they need to actually partner with a larger entity to get some negotiation leverage for prices for drugs and to manage the benefit, because not everybody is capable of setting up a whole formulary and deciding what is preferred, what is not preferred, how to think about cost sharing, what should you put on higher tiers, making them more expensive versus less expensive, and what does kind of adequate coverage look like, and how to do that in a way that saves the employer money so that their premiums don't go up so substantially. So when I first started grad school, I remember going to a conference, and one of the first people I met was a woman who one of the faculty members knew from his graduate program, who worked at Express Scripts, one of the bigger PBMs. And I remember her describing, that they basically help companies with negotiating for drug prices and with formulary management. And I thought, okay, this seems completely reasonable. Like well, of course you would use a group like this. And, I think that what we've seen is very much like what we've seen over the years in other types of healthcare is there has been a push towards more and more consolidation. So there may have been many PBMs at one point in time, but the actual the number of PBMs and their share of the market has gotten very concentrated. So 3 large PBMs make up about 80% of claims that are processed. So they really have most people who are insured have their claims processed by these small number of companies. Okay, I'm gonna pause right there.
I was gonna step back just a little bit.
Yeah.
So just to clarify. So I'm an employer. I'm a Walmart.
Yeah.
Company, have thousands of employees, and I want to offer them health insurance with Cigna or whatever, United Healthcare.
Yeah.
Why do I need that intermediary? Why don't I, Walmart, talk to United Healthcare about the prescriptions that United is going to cover?
So previously, the pharmacy benefits have been kind of farmed out to a different entity altogether. Now, over the last probably decade, but it could have gone back a little bit further, we've seen that health plans have started to buy PBMs. So when we talk about PBMs, over time, they've gone from being more independent and separate companies from health plans that health plans would partner with or, maybe have relationships with to now, like, the health plans actually own the PBM. So they have the same parent company. I think the one that people most often point to is like CVS. You've got the CVS pharmacies, you've got the CVS specialty pharmacy, you've got CVS Health. So you've got like this whole entity of both a PBM, health plan, pharmacies that is all owned by the same parent company. So, I think it is actually a really fair question of, why is this extra company involved here? I think at first it was by necessity that they actually had a specialized business that they offered, these services that could be hired out. But now I think the question is, shouldn't there be more efficiencies available if you have the health plan and the PBM being more one entity? And instead, I think that's where we end up running into some of the criticisms when you think about PBMs and their role in the system is like, they do get paid for these services that they're provided. And that may be adding kind of additional overhead to each prescription in a way that kind of makes drugs more expensive, not just for health plans who may or may not own the PBM, but for the people who are hiring them for their services or paying premiums.
So let's talk about the services that PBMs do. So then the PBMs is this intermediary entity that is going to decide on the coverage of prescription drugs, technically. Mm-hmm. So in that decision making, do they use evidence? Like, do they go and say, the evidence suggests I should cover this diabetes drug versus the other diabetes drug? And then they go and negotiate with the manufacturer to get a cheaper, like is there like a flow diagram in your head?
Yeah, so often they'll have like a P&T committee, like basically a clinical group that decides what should be on the formulary, what should you be offering. So and then what they're going to do, if there are multiple drugs that could be used for a condition, for example, is they are going to negotiate and use those negotiations to decide what gets covered and what gets covered in preferred placement on the formulary. This allows them to get enormous discounts and rebates for the drugs that they are negotiating, because you can say, all right, there are, 3 or 4 drug makers who have a drug that has the same mechanism of action. So we're going to have them kind of bid against each other to get preferred formulary placement. And then in cases where the PBM can exclude a drug altogether in favor of its competitor, they can get really great discounts, because it's either you get access to the market or you don't. And because the market is so highly concentrated among these top 3 PBMs, you would imagine that they could get really huge discounts by saying, like, if you're willing to make a deal with me, you have access to 30% of claims that get processed in the US market. Like that's a ton of potential sales. So companies are going to be very aggressive about trying to get the best discount they can and get on that formulary as a preferred drug. One of the things that you can kind of see, they publish their list of excluded products. So if you look up the top PBM and search, I sometimes will search Google and say, okay, excluded drugs, Express Scripts 2023. And you can actually see what drugs they prefer and what drugs they exclude from their formularies for different conditions. And it'll give you a good idea of kind of generally the different strategies that companies are taking.
So then there's a P&T committee. They review the evidence for these drugs. They decide who they will cover, who they will not cover, and sometimes they exclude. And they have tiers, like tier 1, tier 2, tier 3.
Yeah, usually so, yeah.
Okay.
Right, and the tiers basically are just a way of flagging, how much is it going to cost the patient when they want to access the drug. So the lower the tier, generally, the cheaper the drug to the consumer. So if I were a drug company and I wanted to be, and I had a brand name drug, maybe the preferred brand name drug is put on tier 3, and then the non-preferred drug is placed on a higher tier, costs the patient more money. So I think that typically that's one way that companies kind of negotiate is I'll give you a better discount, but I have to be on a lower tier than my competitor, or I'll give you a really great discount and you'll exclude my competitor. And I think likely it's the case that these clinical groups and P&T committees are probably trying to decide about like, where can you actually exclude drugs versus where you need to have all of them available, but just at different prices. And I'm sure that the other thing that companies are probably thinking about, or PBMs are likely thinking about, is what do employers want and need? Because that's often their consumer, is like the employer is hiring them to manage the benefit. So you don't want to offer a benefits package that makes everybody upset because the employees can't access any of the drugs that they need. So they have to balance that. They want the customer to have a good experience, because if the customer is always upset, then the employer may stop using that PBM in their services.
So in terms of the drugs, though, that the PBMs are providing coverage for, these are all drugs, including cancer drugs, including, but they're all oral drugs.
They can also, I think, have a role to play in the infused drug market. I don't tend to think about them as much in that space, but I would assume, especially in commercial health plans, that there's a little bit more of a role for them. And maybe part of it is thinking about things like prior authorization and step therapy and those sorts of utilization management tools, at least in managed care. I think one of the challenges is I spend so much time thinking about Medicare, and it really is somewhat different in that space, because PBMs really play a key role in the Medicare Part D program, but not in the Part B program.
Right. So who are the top three? Express Scripts?
It's CVS Caremark, Express Scripts, and Optum RX.
Optum RX. So these are the top three PBMs. So they are negotiating, they look at the drugs, they negotiate a price with the manufacturer. So the manufacturer, let's say they charge $500 per the drug. They say, we are going to take it for $400, but we are going to put that as a whatever tier. So it's like a negotiation thing.
That's right.
That negotiation, is it based on evidence? Like, your evidence is weaker, so we are going to put a different tier, or is it just simply negotiation skills?
It's a good question. My understanding is that insurance companies do consider cost effectiveness and things like that when they're thinking about what to cover, what to pay for different things. So I would imagine that it is weighing in a bit. The other thing that also really matters here is basically what are the rules for the different group that you're dealing with. So if we're thinking about how PBMs work in the Medicare Part D benefit, there are protected classes of drugs where there's no allowance for formulary exclusion. So for cancer drugs, for example, you can't exclude any of those from the Medicare Part D benefit. So in a negotiation, if you are told like you can't exclude anything, you have to accept it regardless of the price, you can imagine that the negotiations don't go as well for the PBM or the health plan in those situations, because they need to be able to threaten to exclude a drug to get a really deep discount. So I think the other thing, like in the Medicare program, is there are rules about how many drugs have to be offered to beneficiaries within a class or across a different disease area. So you have to have certain minimum numbers of drugs available to people. So it makes it harder to exclude in that case and meet all the formulary rules that are required. Commercial plans probably have much less of that going on, but also, again, have to be thinking about like having enough coverage so that it meets the needs of the customers that they're working with. So they're also trying to balance that out. But, I would say even beyond like any cost effectiveness or value considerations, like I think one thing is they're looking at how much competition is there. Can they exclude? Can they reduce the number of drugs that they pick so they can get better deals? But often what happens is, with an expensive drug, there might not be competition. So like in the cancer space, we run into this a lot where you really don't have any other options for people. So you need to cover this drug. And you don't really have the levers you need to get a lower price. And so what tends to happen is those drugs may be put into a very expensive formulary tier, like a specialty tier that requires people to pay a lot more if they want to access those drugs. The bad thing, I think, in this case, or one of them, is that at least in the Medicare benefit for a long time, what we've seen is all the cancer drugs were placed in a specialty tier. And it didn't really matter if you were talking about Gleevec or you were talking about something that just had like barely any benefit. It didn't matter. It was all going to be similarly expensive to the patient, which is a terrible idea because you're like, oh, we know some of these are basically functioning to like as a cure, but you need to take them regularly. And then there are other drugs where we just feel like we're not even sure it helps people and it may add, side effects and other things that are bad. And it's still similarly expensive. So I think that's one of the hard parts about formulary management is some of the tools that I think plans and PBMs would use to get better cost or to think about making benefits more favorable for patients. It sometimes doesn't work out when the drugs are just really expensive.
I mean, listening to you, Stacie, it just like, again, what you're describing should be net positive for the PBMs. Certainly, they're not perfect, and like you just described a scenario where obviously there's a huge room for improvement, clearly. But it appears that it should be net positive. Yet, I think we all see that everybody says they're net negative, they're awful, terrible, all of that. Including sometimes I've been vocal a little bit about them as well, but I don't know as much as you do about this. So let's separate perception from reality. I mean, when you look at them, how do you evaluate their need, their role in the healthcare ecosystem, and are they good or bad? It's a loaded question because you take as much time as you need to answer it.
Yeah. So I think this is a really important question. And I think this is one reason why I like to try to level set.
That's your next NEJM paper, I think. Yeah, I have a feeling.
Well, I think it's important to remind people of why they exist and what they're doing, because, I kind of made a joke in one of the last lectures I gave on this about how, drug manufacturers and health plans just are very publicly point at one another as being the problems with drug prices and access. And, I kind of made a joke that PBMs just like try to hide, like they try to like they don't want to be in the picture. They're like, we're not going to say anything, no comment, no comment, no comment. It's like, so they never really stand up and argue about what their role is. They just try to lay low. One of the other things that I think is incredibly frustrating and why there's so much like unknown is because so much of their business practices are confidential and hidden. So we don't know as much as we would like. And I think that really bothers people. I remember hearing somebody say something to the effect of like, when everything's shrouded in secrecy, you pretty much could bet like they're doing something wrong, like there's something bad. So like you just kind of think that with all this secrecy, it can't be good. So I think that they set themselves up to be criticized pretty regularly because both they don't step up and remind people of what they're doing, and they also are literally by definition middlemen, and no one likes a middleman. So I think that to me, it always is like, well, they don't really fight back, but they just sort of like, we'll just absorb it and money. Yeah. So like,
Yep. Yep.
um, so the bad side of the PBM space is, they make a ton of money and it's not completely clear how much additional value they're bringing or if that compensation is fair given their role. So I think that that's one thing that people find to be concerning is like, we know that sometimes that they're paid based on how much rebating they get. So like if you get a huge rebate, they maybe get a percent of that, or they sometimes get compensated as a percent of the savings to the health plan or things like that. And I think people find that worrisome because, and we'll talk a little bit about rebates and why
Well,
that's worrisome
but
too.
I gotta tell you, as you describe this, is there any other source of revenue for them though? I mean, it's either rebates, right, from the manufacturer or how much I'm saving the health plans. And I think, I guess I'll go on the record that I think payers' business model is to deny care. I mean, the
Mm.
way payers actually make money is if we provide less care. Now, sometimes providing less care is better. I'm not saying we need to do more care, but
Yeah.
literally that's how they make money. I mean,
It's certainly one of the ways that they can sell themselves to an employer or to a health plan is to say, we reduce specialty drug spending by X dollars, right? Because I think one of the ways that they gain customers or have companies who want to sign up with them is they're able to say, we've kept your premiums from going up more than they would have without us. And we did it by tightly managing the specialty drug benefit. What does that mean? It means we denied access to certain drugs, we made it more expensive for people and discouraged use, or we really got, in some cases it could be good, where, like you said, we are not overusing drugs that have limited benefit. We're spending the dollars more wisely. But yeah, absolutely. Like that is one of the things that I think they need as part of their sales pitch is that we helped you manage your drug spending in a way that resulted in slower growth in premiums, which is what employers and those offering health plans are looking for. The companies, they either are getting sometimes a percent of the prescriptions or rebates, or they could get a flat fee for the services that they're providing. We also don't have a ton of transparency into the mix of those financial arrangements. So again, like it leads to the suspicion that maybe they're taking up more than they need to. And pharmacists are like livid about the role of PBMs because often one of the other things that comes up is like they kind of are involved in the middle of this transaction between the health plan and the pharmacy. And so they're basically paying the pharmacy for the drug that the patient received, but the pharmacy might have paid more for that drug than they get paid back by the PBM. And then there are these clawbacks that sometimes can happen later where it's like, oh no, pharmacy, now you owe us a bunch of additional dollars back without enough kind of input about like why they're needing to take back more money. So I would say that if you talk to kind of the average pharmacist, there is a very negative feeling about the role of PBMs, but partly it's because, it's like they are basically trying to save as much money as possible, and the pharmacy is going to be the one potentially that gets harmed by that because their whole financial transaction is a completely separate part of the supply chain. It's like the pharmacies independently buying drugs at a certain price, and they're getting paid by this other entity who's negotiating prices on the other side. And so sometimes that doesn't match up, or it could set you up, especially for small independent pharmacies where maybe they've overpaid for the drug relative to what the PBMs are going to pay them back. So there's a lot to criticize.
but that's an interesting piece though, because you just we just talked about how, for example, CVS, which is
Mm-hmm.
a pharmacy, now owns CVS Caremark, which is a PBM.
Yeah.
So like if you I mean, So it's almost two business units within the same company, but they're really butt heading. Like, what's going on there? Like, I'm thinking if you're the top dog at CVS, you're okay. These are two, you want both of them to be okay.
Well, yeah, and it's who gets harmed by this payment. So you could imagine CVS Pharmacy is able to negotiate really good deals because they're purchasing so much drug from a wholesaler. But your small independent pharmacy, who's like a one pharmacy in a town, doesn't have that negotiating clout. Maybe they're working with a group purchasing organization, so they've got some kind of additional negotiation that they can do through group purchasing. But I think one of the things that has been heavily criticized is like, CVS Health, they have to be careful about this, but they could potentially like pay their pharmacies better than they pay the independent pharmacies when drugs are filled there. And so it kind of squeezes out these independent pharmacies, which is something that we don't want to be doing. But we are literally seeing this happen in every aspect of healthcare. So you look at like independent oncologists, and any group that's independent has had this kind of push towards moving into a more consolidated, larger entity who can do these negotiations with these other consolidated industries. So health insurance, PBMs, healthcare systems, all of them are kind of moving into these larger organizations. So then they have more negotiating clout to get better payments or to get, better reimbursement at the pharmacy. But that is, I think, to me, is one of the more important criticisms of this model, is that it can be really harmful for that smaller independent pharmacy practice. And we know that those places can be really great for patients who have long, seen the same pharmacist. They like to go to the local place in their town. And so I think that is a key concern. So, good or bad, or I think it's.
I'll tell you
Yeah.
though. I think some of the reasons, I guess one of the most critical reason why PBMs are criticized, heavily criticized, is because the concept was good. Like conceptually, if you're acting on my behalf, I'm the patient covered by Walmart, and you're acting on my behalf, you're getting the right drug based on evidence, you're saving my employer money, so my premiums are down, my copays are down, all of that. And conceptually, it's great. But I think patients or members don't see these savings. And I think that is really the most important criticism is, they exist. They told us they want to do something to help us reduce our out-of-pocket cost and potentially the healthcare expenditure, which is, this is something you're the expert at. But patients have not, reaped the benefits of what has been sold to them.
Yeah, I think that segues nicely into kind of what happens with rebates and why patients don't get to feel that they are benefiting directly from these savings generated by the PBM. So, one of the key ways that PBMs work is through negotiating rebates that end up getting paid well after a patient has filled their drug. Sometimes these are based on volumes of sales. So it's like, your negotiation might say, okay, well, yeah, I want to be in the preferred placement on the formulary. That way I expect you to generate more sales for me if I'm a drug manufacturer, because I am the preferred drug. And then based on how many sales there are, maybe I give you I have a certain levels that you want to hit to get a certain rebate. But all that gets kind of figured out at the back end. So, and unlike most other things we purchase when we talk about rebates, that doesn't go to the person who filled the drug. It goes to the drug companies, from the drug companies to the PBMs and to the health plans. There are two concerns. One is like, how much does that money go back to the health plan? So in theory, what you want is the PBM to have negotiated and then give that money to the health plan, so it keeps the premiums low for everybody. But there is this big question mark about like, how much does the PBM take before sending the rest of the dollars. And we don't have transparency here. I will say that there have been some investigations in this in the Medicare Part D program, and those dollars all do get sent back to the Part D plans. But still, the PBM is making a ton of money in all those transactions because they're getting paid fees instead of rebates. So
I think people, I don't think people would care if somebody else is making money as long as they also benefit. I think that's really where the issue. I think what the sense is that the payers are stock prices going up, the PBMs are making money, and we as consumers are not seeing anything.
So I think this is where it gets complicated in the what we're being told in general is that this acts to keep your premiums from going up. Yes. That doesn't feel like savings to us. But if you look at what premiums look like on employer-sponsored benefits, so like for a family now, employer-sponsored benefits for a family are over $21,000 that your employer and you together are contributing each year on average in the US. That is like, every time I think about that, it's like, that just blows my mind. That's the amount of money to have what I would consider not great coverage. I mean, most of us have health plans that we think are pretty not great. I mean, I work in a medical center and I have a high deductible health plan, and it's like, I don't have great coverage. I even have this crazy benefit that they've put into place, which we're writing about. We want to kind of give people a heads up about, where like I don't really have specialty drug coverage. I have to go through some kind of crazy hoops to determine like what I have to apply to patient's assistance to get specialty drugs covered on my health plan. So, I think when we think about savings and how the PBM works, and in theory, what's happening is all these negotiations are benefiting customers, but they're doing so by not allowing the premium to grow faster than it already is. The problem is we're spending so much money that it feels like our premiums are continually going up or our benefits are getting worse. And so it doesn't really feel like savings to us. It's just, if you figured out, if you banned PBMs, what would happen? Or if you banned their rebates, what would happen? We actually have an estimate of what this would do to spending in the Medicare program, because the Trump administration attempted to ban rebates in Medicare Part D. And they estimated that it would just balloon the Medicare spending on drugs, because if we banned rebates, basically it would rely on drug companies to lower their prices voluntarily. They've said they won't do that. So it would basically be like reducing any kind of competition we had in the system, and would drive up spending, which would then drive up premiums. So I guess the question is like, are we better off without them? I think the answer is no. But one of the things that I think policymakers are really focused on right now is this issue you bring up about what patients have to pay and that they don't get those savings. So in the way that our benefits have evolved over time, we're basically all being asked to pay more out of pocket. So maybe you pay a deductible or you pay a coinsurance, and you're paying that based on that inflated price that is not what your health plan has negotiated, but that like original starting price. So if I had a drug that like I usually say, like if I had an anticoagulant, maybe that's $500 list price. And then your health plan later gets maybe a 50% discount because there are a lot of competitors in that space. Well, if I'm paying $1,000 deductible in my benefits, I have to pay that full $500 price, when I go to the pharmacy. And later on, my health plan gets $250 back, and they don't give me any of that. So I think that is something that policymakers and patients feel very frustrated by. And I can absolutely understand why. It's just like how to fix that in a way that kind of also
But
doesn't,
I like your
yeah,
contrast of let's think PBMs don't exist. Let's take them.
yeah, yeah,
I think that's probably the best way to tackle this. Take them out. What would happen? Let's think through this, almost
yeah.
like a thought experiment. What would happen is that the the employer the employer will need to negotiate directly with the payer.
They
So
would need to negotiate with all of the drug companies. So I think this is the thing that
why
ends
would
up,
the drug companies? I'm the employee. I'm so for example, I am
yeah,
Walmart, like go back to Walmart. I'm Walmart. I would go and shop around with the payers directly without the PBMs and say, but I think the PBMs are forced on me because we're assuming they don't exist. Then the payers will have to go and negotiate with all of the payers,
exactly.
with
Yeah.
the
So
manufacturers.
yeah, so the payers would have to have that expertise in-house and develop that system. But instead, they've long partnered with PBMs where now they own PBMs to do that work. So I think if you wanted to completely remove them from that system, it would have to be like a company working with a drug, like basically Walmart negotiating with drug companies to get discounts or deals and to offer and manage a formulary. So you really do need that expertise. You just think about how many drugs come to the market, generic entry, all these things that are decisions that you want a company to be making strategically about like what's best, what'll save the most money, what's good for patients. Um, so it's like their role is really important. It's just the question I think that is useful to answer is like, are they overcompensated for their role in the system? And why aren't we getting any efficiencies for the health plan owning that PBM? Why doesn't that streamline things in a way that allows the health plan to offer a better deal? And I think to me, this comes a little bit back to some of the challenges we have when we think about what health plans are allowed to do. So they have to use a majority of your premium for actual healthcare related spending, but they don't have a ton of incentives right now to keep spending low. So you'd imagine like, why would a health plan want to keep spending low? It's to offer attractive premiums to people in their area. So if companies are shopping around for a health insurance product, they are going to try to get the best deal and the best coverage. But again, we've gotten so consolidated that, if your employer said, okay, Stacie, instead of working with this big health plan that's taken by most of the doctors in your area and the best hospital, we're going to go with this other health plan that only has this really small network, but they have a better price. I wouldn't want to work at that company, So like, again, I think we're kind of caught in this area where we've become so highly concentrated in all of these different entities that it makes it hard I think we have to kind of press pause and redo the whole system at once. It's a little bit like our fragmented health insurance system when you look at it and you're like, how do we fix this? And it's like, start over,
Yeah.
I guess.
But let me ask you one other question in terms of the concern is one of the concerns that I hear a lot is that the decision of what to cover and what not to cover is not as pure as we assume. It is not based on clinical data, level of evidence, information. It is really based on economics.
Yeah.
If me and you are two different companies competing for a PBM formulary, they will just go with the one that will get them the best rebate, regardless of the clinical efficacy or the information. And I think that the problem is it's almost going down the rabbit hole because as a manufacturer, I already know who I'm competing against. And if I feel my data is not as good as I want it to be, I'm going to
Mm-hmm.
go and offer a better rebate because I'll take more market share. So I
Yep.
think that's where there's a lot of concern. I mean, as all of us are as patients, you're right about the transparency, but to me, that is my major concern. Like, in addition
Mm-hmm.
to economics, I want to make sure that you're making these decisions not just based on the dollar signs only. You should, it's okay. I'm a capitalist, I'll admit. I'm totally fine with that. I mean, we really need, we need that's totally fine. But you can't really let that blind you.
Yeah. Yeah, I think if you want to hear about the downside of PBMs, go make friends with some rheumatologists who have to deal with this kind of arbitrary nature of like what is covered, and literally just, they might have a preferred drug based on their experiences with their patients and seeing what works best on average, but like they're like, it's totally dictated by the PBM. I have no input at all. It's like I have to figure out what's covered. And I think that the question is like, are there guardrails in situations where there's actually like clinically there's a better drug versus a suboptimal drug? I think the other thing that I hear come up a lot, and I understand the frustrations, are these issues around like utilization management, the step therapy protocols, and the prior authorizations. Those are really cumbersome, and people spend a lot of time dealing with the administrative hassle of trying to get drugs approved. And, I think that for better or for worse, it's like that's in place, to try to reduce spending unnecessarily, make sure everybody has tried the lower cost options, for example, but is very valid for people to be frustrated to have to go through that repeatedly with their patients. It'd be one thing if you automatically were trying to go to the highest price drug without trying other things. But I think where you see this a lot is, this person newly started working at this company, isn't on a new health insurance, and now you have all this paperwork just to keep them on their treatments that have been working well for them. And, I think these are things that need to be fixed. But often when you look back at them, it's like, okay, why does that exist? And again, it's, because there are kind of these push to use newer drugs, and which are often more expensive.
The other one, Stacie, is, I think you brought in rheumatology, is biosimilars.
Yeah.
Right. I mean, you've got, for example, many of these biologics, and then you have the biosimilars that came out. Technically, they're supposed to bring the cost down. It's debatable if they've done that or not. But essentially, if I'm a PBM, I'm gonna actually, if and the manufacturer of the biologic, the original drug, is giving more rebate, I'm gonna say, yeah, we'll use that versus the biosimilar, which could have been cheaper, but my marginal cost became much less because I got a better rebate.
Yeah, and I think this is where one of the things that is so complicated about the biosimilars is that the competition isn't working the way that it does for small molecules. It's like that's kind of how we think things should work, but we don't really expect, like for small molecule drugs, we expect when there's competition, the brand is not trying to compete on price. Like they do not lower their prices. But in the biosimilar market, the brand does lower its price. So you end up, they do it through rebates, but like you end up in this situation where it's like, it's really hard to tell which drug is actually the lowest price drug when you factor in those discounts and rebates, because they're operating in a different zone. And I think for like PBMs, the thing that we should be looking to is, are they getting the lowest price? Period. Because like that's what you want them to be doing, regardless of how they get there. But in cases where they're doing that through very large rebates, are you protecting the patient from having to pay more because of the drug you selected? And again, that's where PBMs get a really bad reputation is, and health plans too, they're one and the same in when we think about this. But if they set it up so that patients are paying based on the list price, which happens quite a lot now, then we should be critical of them using these rebates as the way of negotiating, because it basically then overcharges the patients for their drugs relative to what their contribution is supposed to be. So if I have a health plan that says I have to pay 25% of my drug's price, if I'm paying 25% of an incredibly inflated price, that's totally unfair, because I'm only supposed to pay 25%. And effectively what you're asking me to pay is 50% or more. And that's not really a reasonable thing to do to the patient. So my general view is like, I don't have a problem with PBMs and rebates if we can protect the patient from having to have their price tied to that list price. I think patients should pay copays, period.
Well, you can do that once you get into office. I mean, maybe, you know.
Slowly but surely. They'll be like, she is the most boring person ever, when I'm like,
You have
no,
my vote.
copays for everyone.
You have my vote. I'll vote for you.
Thank
And I
you,
mean,
Chevy.
I live in Chicago. I get more than one vote. I don't know if you know that. In Chicago, we do a few more. Stacie,
I've heard.
This is really very helpful. I think we covered it a lot. It's, you know, I think I'll let you go. You're very busy, but it looks like overall, they're not as bad maybe as people think, but there's a lot of opportunity or room for improvement.
Absolutely. I think under our current system, maybe we could call them a necessary evil. I will say also for your listeners, something that is coming soon is that the FTC is doing a full investigation of the major PBMs, where they are asking for a ton of information to try to provide more transparency into the role that they play in the healthcare system. And this has been largely information that is unavailable to the public and to policymakers. And so I'd say just keep an eye on that. If you're interested in how PBMs work, they are doing a very deep dive and collecting a ton of information from these PBMs about how their business practices are working, so that we can actually get a little more transparency here and think about like, what are the downsides to their current business practices and how can we make it better for consumers? So
Well,
I know that is like the most boring stay tuned I've ever done.
This is great. This is like, you know, FTC investigation. That could be a future documentary.
There you go.
Dr. Dusetzina, thank you so much for coming on Healthcare Unfiltered. It's probably the most we can excite people about PBMs. I think this episode is going to go viral. You just wait and watch.
There we go. Well, great to see you again, Chatty. Take care.